Thank you very much. Um, as our introducers say, we are two doctors from Lublin in Poland, and we are very happy that we have a chance to speak about radial access. And please let me know if you can see my presentation. Yes, perfect. So my name is Maciej Szmygin, and today with a friend of mine, and actually it's my mentor, Dr. Tomasz Roman, we would like to share our view and our tips on how to start establishing radial access as a standard access site in neurointerventional radiology. So this is us. So what are the potential benefits and why should we consider starting radial access? I strongly believe, and we believe that there is many potential benefits, especially for patients in local anesthesia, but also in procedures carried out in general anesthesia. First and foremost, it's less stressful for patients because we don't manipulate the groin area. Also, from our experience, it's much less embarrassment for the patients. Again, the groin area, it's a little bit intimate area. So if we puncture radial access, if we consider radial access, it's much more convenient for the patient. They also can eat and drink much earlier than actually they can eat in more convenient position. So it's much more convenient for them. They are mobilized immediately after the procedure in local anesthesia. So it's a lot of benefits, but it has also a lot of benefits in general anesthesia. It's shorter pre-procedural preparation because we don't have to scrub all the groin area. It's less post-procedural discomfort. Even if we don't have any complication in the groin area, still the patients feel this area quite often. It's a lower rate of access-related complications, and it has been published on this. We will see the data. There is no need for closure device, so we don't need to. We apply the band, but it's removed after a few hours, so it's no need for closure device. And it's more hygienic access site. It's also important for the patients who have to stay in bed for a few days if they need to. So it's a lot of benefits. Also, this has been reflected in a recent survey among patients. It was published in 2020. You can see that this is the percentage of numbers of patients who underwent radial access procedures, and they expressed yes or no on the benefits. So 96% of them said it's much better than femoral access if they had both. It's much less stress, 96%. It's less embarrassment. Actually, it's interesting that only 72% of patients said it's less pain, but it's still a vast majority. Less post-procedural pain in 92%, faster recovery time, no complication is 100%. Eat and drink is also 100%. So it doesn't mean there is no complication whatsoever, but in this group of patients, there was no complication, so they were very happy. So is our thesis that there is many benefits and almost no potential risks true or not? We will see. So this is the short comparison between these two, radial and femoral access. We can see that the bleeding risk is much reduced. It's less than half percent versus 2 to 4% in transfemoral access. Patient can go walk immediately after. There is no need for bed rest. So still, it's better than any type of closure device, any type of pressure applied to inguinal access, femoral access. The guide support, some say it's inferior, but now with so many products and very good catheters, we think there is almost the same, but it may be perceived as a drawback that maybe femoral access has better support. Sheath size, this is definitely something to consider because we cannot go very very high with radial access. This is the clear advantage of femoral access, but in majority of procedures, we can use 7 French, up to 7 French, it's okay. We have a lot of catheter selection. Of course, learning curve, it's a bit steeper because we have to do up to 50 cases to be proficient, whereas femoral access is much easier. Stroke risk is comparable in experienced hands. Of course, there has been some reports on stroke due to radial access, but it's only reports. Fluoroscopy time, it's slightly longer because the catheter has to travel longer. It's preferred access in obese patients and patients with peripheral artery disease. Costs slightly higher, but quite similar. So we can see that there are several advantages. There are a few key areas where femoral access is better, but still we think radial is very good. So what would be perfect indications for our first radial access case? We started with angiography cases. So this is something that I can recommend. Start with angiography case, most preferably with right-sided cases because it's easier to cannulate, it's easier to catheterize. Then if you decide to do interventional procedures, start with easy or maybe more predictable coiling or aneurysm treatment, maybe flow diversion, maybe carotid artery stenting. I wouldn't recommend starting with mechanical thrombectomy or stroke unless it is necessary. You can also try to do embolization procedures, tumor embolization, nose bleeding embolization, maybe easier embolization. And what would be the perfect patient? Preferably maybe a bit obese patient with difficult femoral access, or maybe with advanced PAD, or a patient with rather not very happy memories with femoral access, like femoral groin hematoma or closure device failure, or patient with anticoagulation therapy. So that would be a good recommendation. And what are the contraindications? This is something to bear in mind because if we try to do our first case and we fail, that could undermine whole concept of radial access. So we have to choose good patients. We wouldn't take patients with absent or non-palpable radial pulse. This is quite obvious. But in our experience, we try to we palpate pulse in every patient. If we feel it, it's okay. But then we perform ultrasound and we take patients with at least 2 millimeters of lumen. That's our recommendation. Don't take patients with prior radial artery occlusion or harvest, especially patients after coronary bypass. So these are the patients to avoid. Also, if they had mammary harvest, then you can experience some difficulties traveling through. So avoid patients with coronary bypass. Of course, active infection at the wrist or patients who cannot pronate their wrist easily. These are patients to avoid. Relative contraindications, 2 millimeters of radial artery diameter. We from our experience, we recommend over 2 millimeters as a first patient. Of course, if a patient has planned procedure or planned radial harvest, don't do it because you may lose this access. And if the patient has a Raynaud phenomenon, also don't take these patients. And what about patient preparation? So before there has been Allen test, which we know, but nowadays there is no need to do this Allen tests, especially not routinely. They have limited utility and they may expand the range of contraindications. Do ultrasound, do check if they have both arteries, if they're both patent arteries, and this should be enough. Allen test can be only performed in selected patients. If we have doubts, if we don't know, then maybe we can perform it. Also, we have to be sure that the patient is comfortable, so he can rotate his wrist, his arm. So don't take patients who has some spasm or cannot extend and rotate his arm fully, because it has to be comfortable, more comfortable than femoral access. That's for sure. That's why we have to ensure that the comfort is a priority. Sometimes we also check the oximetry during the procedure. After the procedure, when we put the band over the wrist, it can be very useful. We have to prepare the skin, of course, as for femoral access, and then, of course, local anesthesia, lidocaine subcutaneously at the puncture site. Don't inject it too deep because it can be more painful. It's just to anesthetize. And this is our equipment. So very, very important is to have a wrist board. This is our setup. So we have a wrist board with different adjustments. Then we have a table. This is very comfortable for the patient. Of course, when we started, we didn't have this, and we used some wooden board with some hand support. It was okay, but after introduction of this one, it's very, very comfortable for the patient. We should always have micropuncture set as visualized here. So we have a very thin guiding wire, thin needle, vascular sheath. We have our cocktail, and we have a small blade. Remember that it has to be hydrophilic sheets. Always be prepared to have various catheters, because some vessels may be difficult to cannulate. So always have at least 2 or 3 catheters to be prepared. And of course, wrist bed for hemostasis. And we always advised people who start to try to do hemostasis for a few times, because then in stress it has to be put properly. So this is our recommendation. It really facilitates the access. It's easier for us, but also for the patient. The puncture technique. It's better to use single wall puncture at 30 to 45 angle degree. We have a pulsate backflow. Then we introduce the wire. We always encourage people to use ultrasound. You can see the artery, you can see our needle, so it's very safe. And then we insert the sheath. It's really easy. So we always try to do it gently. The wire also has to go smoothly, so it's very important not to push the wire too much. If we feel any resistance, if we feel any stop, then we have to stop. Of course, sometimes we don't do even the yes. So we introduce it smoothly, right? We remove this, and we always flush to ensure that we are in the vessel. So you can see it's very clean, very nice access. We confirm that we are in the vessel. This is the portable ultrasound, which also makes it quite easy. Very important is to be prepared that we have to inject something after we successfully puncture the artery. It's called cocktail or antispasm cocktail. What we do in our practice is verapamil for 5 milligrams. We have to remember that we have to monitor the patient pressure because it's a vasodilatator, so the pressure may drop, and we have to consult it with anesthesiologists, or if it's in general anesthesia, so we have to be aware. Then some centers use nitroglycerin. We do verapamil. Of course, heparin. We can consider additional verapamil if the spasm is very big. If we cannot get rid of the spasm. So this is how the typical spasm looks like, right? So very thin artery where the guide wire was. This is the prior the. Yes, but we can see proper blood flow to the arteries, no signs of extravasation, no signs of anything worrying, just the spasm. So it's very classical, right? And this is after the vasodilatator, right? We can see it was restored. So normally we have to wait 2 to 3 minutes, sometimes maybe longer. No problem. And what is quite important is to remember that after the injection of the cocktail, the patient may experience rash in his or her forearm. It's normal. So, but we have to tell the patient that after the procedure, after the angiographic DSA, he can observe rash on his forearm. It's normal, so nothing to worry about. It will be gone. So then we have to navigate. Once we have our access obtained, we have to navigate. It's quite simple. It's quite easy. We do from radial artery to brachial artery. Then, if the anatomy is normal, if there is nothing abnormal, then we do axillary artery, subclavian, and aortic arch, and then we try to cannulate the vessel. Here is how what we like is the loop at the end of the guiding wire. Then we are sure that we can go up. What we recommend is always to do it under fluoroscopic guidance. Never push the wire without surveillance. There, if you we know that some centers do it like this, but we always try to see the wire, be sure it has to be safe, that there is no damage done to the vessel, right? So we go up. Thanks to the loop, there is no risk of unnecessary cannulation. Once we are in the aortic arch, we have to form and cannulate the vessel. We use 5 French, most commonly guide catheters, over which we introduce our sheaths. What we in our practice do most commonly, we use Simmons 2 or VTK catheters. These can handle 99% of all vessels, or 95 at least. But it's good to be prepared for and to have a lot of catheters. Yes, in case of if we try to cannulate vertebral artery, left vertebral artery might be difficult, but right vertebral artery is quite easy, so no problem with this. And of course, telescope technique for distal support. And then we have to form our catheter, so to say, right? So we have to go to the descending aorta. It's what we do. We go to descending aorta. There are several techniques, but what we recommend is to go to the descending aorta, not to turn into, not to go into the heart, because maybe cardiologists do so, but we don't. It's always good to go to the descending aorta, maybe sometimes to directly to the right or left carotid artery, but our preferred way is to go into descending aorta. Right carotid artery is usually the easiest one, so it's really easy. I will show you the video. It's quite oftentimes it's quite easy to cannulate. Left carotid may take some time, may take some rotation of the lamp to find it, but again with Siemens 2 or it's quite easy. We can keep wire advanced during catheter exchange, of course, not to lose it. And we sometimes do roadmap fluoroscopy to have the roadmap navigation. So here we can see the catheterization of the right internal carotid, right common carotid artery. Right, you can see that it's quite easy. We inject a bit of contrast to be sure not to go to the right. Again, we inject a bit of contrast not to go to the not to go too far. As in this case, we have to be careful for the vertebral artery. And we withdraw the catheter so that it's now fully in place. And here we have left vertebral artery. Here is the tip of our catheter. We inject some contrast. We have to turn to find it, and it goes into it again. Takes some time, takes some practice, but it's in the place. It's always important to know how to turn and just not to rush, to take your time. It will hop into the vessel. So here are a few tips and tricks. First, we sometimes recommend to warm the puncture site, especially in young female patient or smokers who tend to have big vasospasm. So we can warm the area before the puncture. Of course, it's always good to start with smallest effective sheets, not to go inside the big ones. Hydrophilic sheaths, and of course, avoid multiple puncture. That's why we always advise to use ultrasound, 1 or 2 attempts. Yes, but multiple we discourage, because then the patient has several dots on his forearm, and it's not very good. So we turn clockwise for left aortic vessels, and we counterclockwise for the right aortic vessels. It's quite easy. And then, of course, some vessels are not that easy to cannulate. What we recommend is a telescope for access extension, and what we use sometimes with very good results is to inflate the balloon distally in the vessel, and then use the anchor effect to pull up with the bigger catheter and sheath. It's quite effective if we need to. Okay, so this was also this happened to us during our first case, that it's impossible to know beforehand that we had a patient with recurrent radial artery. So this is the artery that we have to be aware when we start with radial access. It's a branch from the radial artery at the elbow. It forms collateral bloodwork that loops around the joint, and it's especially important in case of artery access, radial artery access, because you will see that its injury can happen, as in this case. This is the iatrogenic radial recurrent artery perforation during the coronary intervention. Luckily, these were cardiologists, so they put a stent here, and there was no aftermath. But we have to be aware that that the artery exists, and these are two examples. You can see. I will put it again. Right. So here we have the artery. There is a small loop, and then there is the small recurrent radial artery, and it's especially deceiving because when we introduce our guiding wire, we have the impression that it goes straight up, so that it goes okay, but then we can have problems. This is the second case, right? Again, tiny vessel, and it goes up again, small loop, right? So we have to be aware of this anatomical variant, because if we go up and we perforate it, maybe the patient will not bleed out, but we will have some bruises, we will have serious pain. So we have to be aware of this anatomical variant, right? So if we see very small artery, we have to be sure, and especially if we see the loop here, we have to go in the main vessel. Sometimes it requires a tiny micro catheter and micro wire. Still, we have to use it to go to the place safely. Okay, and what about hemostasis after the procedure? There is a large variety of bands and compression bands. We have to compress the vessel to avoid bleeding, but we also have to compress it not too hard, to preserve the flow to the fingers, right? So there are different bands. We usually inflate them up to 15 to 18 milliliters of air. We hold it 2 to 3 hours for five French axes, and then we ask the nurses to deflate it a bit, 2 milliliters, or to deflate it 4 milliliters, and check if there is a bleeding. If not, they can release more and more every 15 minutes, and of course they have to monitor for the hematoma, compartment syndrome, and so on. Sometimes what we do, if we are not sure after the procedure if the fingers are adequately perfused, we put oximeter at the finger, and if there's good values, then it's perfectly fine. What we also did in our department, for the first few cases, we showed all the nurses how to do it, because the patient who normally was punctured at the femoral area now comes with the funny band, and they don't know what to do. So it's always important to take care after the procedure, so everyone is familiar with the function. I would like to also mention the distal radial access, because it's an emerging subject. It's a technique that is used to puncture anatomical snuff box, which is distal to radial styloid. Some specialists use it because it preserves proximal radial artery flow. Some say it's more comfortable than conventional radial access. It's quite commonly used in cardiology. And potential advantages is a lower rate of occlusion. I read an article that it's in cardiology journal that it's really lower rate of radial artery occlusion. Maybe it's more comfortable for the patient because they don't have to rotate their arm. The operator ergonomics is improved. Some series report lower spasm rate. It does not compromise the conventional radial access, and the evidence is growing. So we will learn more about this access. Uh, to be honest, in our routine, clinical routine, we don't use it on everyday basis. We don't experience many complication after traditional radial access. We do it only in selected cases when patients cannot rotate their hand. So I don't know if the distal radial is something we will go into. Okay, so because this talk is on how to establish radial access, we suggest a pathway, 4 steps pathway. First, it's really good to at least observe someone who does it on everyday basis. Visit a center on where a lot of radial access is performed. It can also be peripheral interventions. We know that it can be done for a lot of vessels, but try to do really try to see it, try to be aware of potential benefits and drawbacks, and then do some, maybe not 50, but start with diagnostic cases. And then we suggest doing it in elective cases, because when there is stress, there is rush, maybe try to use femoral at first. Always prepare femoral as backup. If there is anything going on with the radial access, try to have this as a backup, and evaluate on your technique gaps and on your experience with radial access. If you master early phases, then you can try with more difficult cases like left vertebral artery, which can be very, very difficult. And then move to complex embolization, maybe try distal radial access, maybe try left radial access, and really have fun with it, because in our opinion, it's really, apart from a lot of benefits for patients, it's just more fun for the physicians. Just a quick overview on complications. What we experience the most is radial artery spasm, but it can be really handled with antispasm cocktail. In very few cases, again with young female patients or heavy smokers, we may experience some troubles with severe spasm, but we just have to wait, and it will be gone. Radial artery occlusion is something that occurs. In our experience, it occurs every now and then, but we never had a patient who has symptoms from this. That's why we always check if the patient has both arteries, ulnar and radial. So this has to be checked. It happens. The patients do not report any troubles. It's usually asymptomatic. Access site hematoma also can happen. That's why we always try to use ultrasound. Still, it happens. It's nothing really serious. And some more serious events like fistula, nerve injury, or hand ischemia. To be honest, in our experience, we do it over 4 years now, or even 5 years. It has never occurred, but it has to be mentioned that it can happen. Here is the view of pseudoaneurysm. It's from the internet, because, as I mentioned, we never experienced this. And this is the severe spasm. Again, some clinicians use long sheath to eliminate the radial spasm. So it can be an advice, maybe. And now, if we move to the catheters that we use and to guide catheters, nowadays we have a lot of catheters. They're really good. Some have benefits other than the others. But of course, what we try to highlight in this webinar and what we can really wholeheartedly uh, recommend is the FUBUKI catheters. We use them in our daily practice. Its main advantages, it's really that they're flexible when they need to. So they have soft tip and flexible distant shaft, which minimizes vessel injury, and we never experienced any vessel injury with FUBUKI catheter. Its pushability is really well, so it's really good. So it's flexible when it needs to, and it's rigid when it needs to as well. So it's really provides stable deployment, optimal push. Its distal hydrophilic coatings allows smooth navigation. So it's really something to be aware, especially in the left carotid artery, and it's really good visibility. Again, there are platinum marker on the tip. It's really good to visibility, which sometimes it's also can be tricky if we go up. So it has to be taken into account. We can see that there are 4 different kinds of materials, gradual change of shaft solidity. Really, we can, from our experience, we can say that it's really solid. It provides solid solid support, and it's flexible at the top, so it's really good catheter. Yes, so this is we have straight and angled, depending on what we want. We can also see that it has hydrophilic coating length of various size. It's 15 or 5 centimeters. But what I would like to show the most important is it's really the variety of lengths and sizes that is available. We can see that we have 6, 7, and 8 French. It has really good inner to outer diameter ratio, so it's really convenient. And we also have different lengths. So it's up from 80 to 110 centimeters. It covers 99.9% of every patient. So in our experience, the main advantages of FUBUKI catheters is that they are hydrophilic. So even in case of radial spasm, it's easy to maneuver it, to get out. It's really good ratio between outer and inner lumen. It's quite stiff at where it needs to be, so it provides good support, and it's really good for us. It's really cost effective, so we can recommend it. So in summary, what we would like you to take away. So in our experience, radial access is really safe and effective for nearly full spectrum of neurointerventions. We still acknowledge that there are cases where femoral access is very important. It has its role. Its key advantages is reduced access site bleeding. It's for us. For the patient, it's immediate ambulation and improved comfort. And over the years, now the patients come to our clinic and they ask for radial access. Really, it spreads among the patient. They are happy with this. Also, the clinic profits, even if slightly, it profits in the beds, and it lowers costs. So it works both ways. Our recommendation is to start with diagnostic cases, and especially right-sided cases. Be aware that the radial spasm will occur. Always have prepared your antispasm cocktail and the smallest sheath. About the distal radial access, we will see. It's the emerging technique, so it surely has its place, but if it will be done routinely we don't know. And we dare to say that the future of neurointerventional is transradial. So we have to adopt it early, we have to train systematically and track our outcomes. Again, here is my number and my email, and here is the our website of our neuroradiology team. And I would like to say again, thank you very much for the hosting team. And if feel free to ask questions. Thank you very much.
Thank you very much. Very, very nice. Amazing. I would like to ask your colleague, Thomas Roman, about what he is saying about distal radial access, and especially if neurointerventionalists are this time quicker than cardiologists or not.
Let me start with short anecdote, because I am the guy who finally made first transradial cases in our center. Well, so I was, of course, asking our cardiologists about the tips. They gave me 2 tips to start with. First one was to try and start with tall, big male patients, because they are easiest to puncture. They were very right about that. The second advice was that I should use a simple steel J wire like 32 and not to use X-ray on the way, just start X-raying when I feel any resistance on the way. And it turned to be a very bad idea. So we didn't adopt this one. We try and use navigation at all times. When you ask me about a distal radial approach, well, it has its place, especially for patients which have some disabilities or some orthopedic limitations to the hand or arm movement. Sometimes it's very difficult to put the patient in the proper way so the radial access is open to us. So it is impossible to maneuver with arm and hand efficiently. So in those selected patients, there is a role for distal radial puncture. We strongly advise to use a ultrasound guided puncture to start with. Of course, there are several studies which will tell us that the diameter of radial and distal radial artery and the puncture site should be virtually identical. So we should not be worried that we should use smaller introducers. We can use up to 7 French as well. But still, I would just strongly recommend using a ultrasound to do the guided puncture.
Okay, thanks a lot. Very detailed answer. I have another question for you that was raised from the audience. Which size of FUBUKI do you use regularly? Which French size and which lengths you prefer in your hospital and why?
Okay, this is really a very practical question. Thank you for raising this thoughts. First, we try to go as smallest as possible. In our center, 6 French is more than enough to bring up to microcatheters. We try to use for aneurysmal treatment as small microcatheters as possible. I'm not sure about branding names, but we try to be able to bring up the balloon or another microcatheter in case our case should go wrong. And 6 French, in our experience, is more than enough. Of course, when we plan to use 3 microcatheters, for example, in dual balloon technique, or we want to have additional backup of 3rd microcatheter for some reason, 7 French is more than enough to do the job. But as I said before, we try to use low profile 6 or 7 French introducers. As for the length of the catheters, we strongly believe that the length of 105 is the perfect one to do the job, because we should add like 5 or 8 centimeters more to your standard femoral catheter, because there's slightly longer way to go with the radial approach.
Okay, thank you. Thanks a lot. Are there more questions? Christoph? You have a question?
Yes, I have a question. So first of all, thank you for this great presentation and for your insights. I find it was amazing and was a really good overview for the access. And my question is, when we see the neuro field, we have all devices, an example, flow diverters, intrasaccular devices, microcatheters, and the guiding catheters was constructed for the femoral access. Do you said, or in your opinion, you have devices in your daily practice? Do you said, okay, it's good for the transradial access, or you said, no, you can use all devices, it's not a problem for you?
It's pretty exchangeable. I mean, all transfemoral catheters can be easily used for transradial approach as well. Please keep in mind that the most important feature of your transradial catheter is aortic arc stability. Sometimes it requires for you to go as low profile as possible. For example, the internal carotid or vertebral artery can be very narrow, tortuous and stuff. So in those selected cases, sometimes you have to aid yourself with other techniques like bringing up some body wire, I mean to increase temporarily a stability of your system. But at the end of the day, I believe that majority of transfemoral catheters, guiding catheters, can be safely used in a transradial approach.
Okay, thank you. According to the product combination, what you said, if you would have the opportunity to work or to construct and give feedback to a company like Asahi Intec for a even better product for radial access, what would be needed to be changed?
I would ask the company to study all of the cases when there is a protrusion towards aortic arc. I mean, this stability is the utmost feature you have to care about when constructing your ideal transradial guiding catheter. Also, the tip stiffness is very important. We believe that ability to bring up the catheter towards the petrous segment of internal carotid artery adds also a lot towards the stability. There are also attempts being made on the market to create a catheter with balloon at the tip to additionally give the possibility to increase the stability if needed. I believe creating 8 French catheter for transradial approach is not necessary so far, because we are more and more efficient with transvenous approach to arteriovenous malformations treatment. But for transradial approach, we believe 7 French is more than enough.
Thank you. Dr. Szmygin, you want to add something?
Oh, I just wanted to ask Christoph if we understood it correctly. So you asked if there is any device that we don't introduce transradially, but we would introduce transfemorally.
Yes, of course. Or specifically the question. So we heard also. So the axis, it's the important point for the case. And is the radial axis our tool or our religion? And then it's the question. So okay, when you use an example web device, contour, stent assisted coiling, balloon assisted coiling, then you said, okay, here is for me, in my opinion, or in your hospital, the radial axis our option, or you said no, of course we are use here only the femoral axis, more stability, better compatibility with bigger catheter. So an example, yeah.
Yes. So I think that now we switched to radial access in all cases, except for, of course, some malformations. Also with intrasaccular devices, also with balloon assisted coiling. What we sometimes have to do is because we don't do in every patient, we don't scan the aorta and the aortic arch. So sometimes if we cannot obtain stability with any method, then sometimes we switch to femoral artery. But now we really do 99% of patients that can be done transradially. We do it with also ruptured aneurysm and non-elective cases. Of course, with ischemic stroke treatment, that's a different story. We did few, but it's not preferred access. But apart from this, if there is a possibility to do it radially, we start with radial access.
Are there still questions in the audience? Please just unmute yourself and ask them. It's your choice now. Okay, I have one more anyway. Young physician like you, are they in the future doing more and more radial access? Yes or no?
Speak of myself, I think yes, mostly because of increased safety of the access itself. Also, for the increased cost effectiveness, it can add some points to decrease in-hospital stay, for example. And at the end of the day, you cannot have strong complications on the puncture site afterwards. So I think, yes, we will eventually switch to radial more and more. But as some of you mentioned before, we don't have to make it an religion necessary, because transfemoral approach has still its place, for example, in stroke, in LVO treatment, because there is constant increase of diameter of aspiration catheters and guiding catheters, which we eventually will not be able to bring up through radial access. At the other hand, we cannot cut down our technical possibility of removing some huge clot burden in selected cases. So yes, I believe there is a strong role for a femoral approach so far, but I believe in any patients that require preload with dual antiplatelet treatment on articulation for some reason, the safety of transradial approach is very important to consider.
Thank you.
Yes, I can only agree. And I think that in our center, more and more peripheral procedures are performed transradially, like myoma embolization, like TACE procedures. It's really good for the patients. It's really, they learn from neurointervention and they do it. So it's really something to consider.
Nice that they learn from neurointerventionalists how to use radial access.
It's a funny story, but yes,
Yes.
it's actually what happened.
You have the power in your hospital. I already see that. Are there more questions? Wait, I'm looking in the chat. Which FUBUKI do you use? Okay. So writtenly, I see no more questions. Are there more? It's your last chance. Still 32 people on the call. No more question? No, no more question. Okay. So if there are no more questions, I would like to say thank you